So dystrophin is located on the chromosome X, which means that the disease affects mostly the boys. There are some girls who can be affected. Sometimes we understand why, because they have, for instance, Turner syndrome. Sometimes we just don't. And the mutations can be inherited from mom. It's the case in about 50% of cases, right? And in 50% of cases, it's what we call allele mutations. And that very rare case in when the mother is what we call a mosaicism, which means that she has the mutations in the ovarian, but not in it cannot be found in the blood. So we, even if in ladies who are not carriers, we should be careful and propose diagnostic, interodiagnostic in boys, for boys. So of course, the fact that the possibility of recurrence will drive our strategy to manage these families and to propose to try to decrease the risk of recurrence of Duchenne muscular dystrophy. And then comes the questions of the diagnostic and how we manage it, how it happens in several countries. And I think that Zoya Alashwani will be certainly the best person among us to explain us what is actually the journey of the diagnostic for Duchenne muscular dystrophy.
Talking about the diagnosis, and at the moment children will be tested for the condition if they present with symptoms. And if you look at different countries, and there are different points in time where data was collected, generally we remain at diagnosis between ages 4 and 5. Obviously, children, when you go back in the history, there are some symptoms that parents may have noticed in early childhood, and we have come across situations where families approached health professionals and they had some subtle worries, and then they asked multiple people before they got to a stage where testing happened. So there is a time lag, we noticed, between when the first concern started, first symptoms noted, and the time of diagnosis being made. And multiple professionals can be approached. So health visitor tends to be one that the parent may talk to, but they can present in any clinic. Some of the children might present with toe walking in an orthopedic clinic. Sometimes it's the physiotherapist who first saw them. And sometimes they even present to a neurologic. So any professional could come across these children. Just to summarize, different signs and symptoms that these patients can present with. And there is quite a lot of overlap with a lot of other neurodevelopmental or developmental disorders in general in early childhood. Motor delay is very common, but there are other things that parents might also report. And one of the common ones could be activities against gravity, so getting up from the floor, climbing stairs. However, remembering this might not be something immediately noticed at the beginning, in particular if the child has a neurodevelopmental delay, which is common, as we already mentioned, in Duchenne muscular dystrophy. Some of these signs may be put as a part of a global developmental delay as well. Occasionally things can be, the children can just present with a speech delay to start with, and that might be the most marked thing. And we will come to that later, but there has been situations where liver transaminases was done for a different cause and was found to be raised, and then we realized this was from a muscle origin when CK was tested. So if you were to suspect that the child has delay and you're thinking, oh, I need to rule out Duchenne muscular dystrophy, then it's very simply including CK in other tests you are doing. And CK test, which is creatine kinase, which is an enzyme that is present in the muscles, and it will leak in the bloodstream because of that disruption of the muscle fiber that it results from the lack of dystrophin protein, as we already explained. And this is a cheap test. It's quick. It's available in all hospitals, including district general hospitals. So if you have a child with any delay at any age, CK test should be one of your main testing panel, really. And the majority of cases you will test when the child has developmental delay in any area, even if it's not mainly motor, will have a normal CK, but you will have situations where CK will come high. Now, there might be situations where you saw the child and you're strongly suspecting a muscular dystrophy and you're expecting CK might be high. There might be other situations where you did it as part of your general investigations because the child is delayed, and then you get surprised that the CK is high. And this is why it's good to have a little bit of a frame of what you're going to do in those two situations. If you're strongly suspecting that CK might be high and you might be going down the route of investigating for a muscle weakness disorder, muscular dystrophy, then you might want to give the parents a little bit of a warning that you might be expecting that, and have some agreement of how you're going to communicate the results to them, because the CK test comes back on the same day or the next day in majority of hospitals, and how you're going to communicate that to them. Bearing in mind, the moment you say creatine kinase to parents and they Google it, that's the first thing they will come across, which is Duchenne muscular dystrophy, and all the information on the internet gives them lots of alarm. So if you're strongly suspecting it, you might want to give them a bit of warning that you're expecting that. And it would be a good idea to take a DNA sample at the same time you're doing testing. Now, if you're suspecting muscular dystrophy, you'll take a DNA sample and you'll warn them that you will be testing the dystrophin gene if the CK is high. If you're not and you're doing general developmental investigations, you anyway might want to take DNA sample because you tend to do microarray tests for a child with developmental delay. So it is a good idea for anybody with delay to take a DNA sample at the time, warning them you might need further genetic testing. And then have a bit of an idea from your genetic lab of how long the results come. We'll talk about testing of the dystrophin gene a little bit later, but you initially will be looking for deletions or duplications, which will look at about 70% of your gene mutations. That's a test called MLPA. And if that's normal and you had a high CK and you're suspecting a dystrophy, then you'll go to point mutation testing, which takes a little bit longer. So you want to have a little bit of a plan of how you're going to communicate results. We had situations where parents have been phoned with test results, and that is really not good practice. Ideally, what you want to do if you get a really high CK test, usually in Duchenne it's in the many thousands, what you want to do is have a discussion with your local neuromuscular center and do an urgent referral, saying to parents that CK is high, you're suspecting a muscular dystrophy, you're looking for the most common one, and you'll make a referral. In it, you can initiate the test for the dystrophin gene yourself, but then if the result is going to come to you first, you do need to have a planned face-to-face, thinking that that's when the results are going to be available, or have a plan with the neuromuscular clinic whether they are going to see the patient and give the results, because it can be very traumatic to give results over the phone. You do need, and if we move to the next slide, and this is what we do in the neuromuscular clinic. So I sometimes in my neuromuscular clinic will see patients already have been given the diagnosis because they had it in the local pediatric clinic, or they referred to me with high CK and I've done the testing for the gene and I give the parents results. And I usually say to them, I will not give you the results over the phone, we'll arrange an appointment, and I try to time the appointment and when I'm expecting the result to come. And Usually we meet for the giving the news about the diagnosis if we have a confirmative genetic diagnosis, and give information as much as you feel the parent is ready to have information, and obviously have some written information ready as well about the condition. Now, what you ideally need to do, because if you imagine what will happen when they first get the diagnosis and they've already might have Googled a lot of things online, is that the amount of information that will go in and the amount of trauma at that first appointment is sometimes difficult. So this is the important role for a nurse specialist or a neuromuscular care advisor to follow up with the family in the next few weeks. There are differences between families of when they want that follow-up to happen. We ideally arrange a home visit to discuss more. Sometimes the parents want to come back to clinic and discuss with me in the next few weeks, and we offer that opportunity as well. We discuss referring to cardiology for a baseline heart assessment, to endocrinology for bone density scans to look at the bones, and to the genetic team for mutation screening for mother, and also for talking about future. Physiotherapy interventions are very important from early on, and obviously the educational setting and what modifications the child need. There are in lots of countries also helpful charities and lots of information. You might want to signpost them to a lot of good places where they get measured information, because there is quite a lot available on the internet which can get families lost in it. And obviously discussing of steroids will be dependent on the child's age, but also on the readiness of the family.